Good evening, everyone, and good day to others who have joined from other time zones. Today is the 10th Masterclass. Masterclass is the monthly online academic activity of the Jaipur Surgical Tutorial, which is again an online education portal that we started when I moved from Lucknow to Jaipur. And this is being managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplant with me at the Mahatma Gandhi Medical College and Hospital in Jaipur. This program has been running for last 3 years. In between, I'll keep projecting information about the Jaipur surgical tutorial. We conduct a class every Saturday, 9 to 10 a.m. India time. In addition, recently, a few months ago, on the request of colleagues from Africa, we started a Friday afternoon activity, Jaipur Surgical School, where we hold a class 3 to 4 p.m. India time, and that has been managed by Dr. Piyush Varshne, who's my colleague at AIMS Jodhpur. And master classes are actually single theme sessions which we hold on last Thursday and Friday of every month, 7 to 9 p.m. And as I said, this is the 10th master class. We covered living donor liver transplant, safe coli, acute pancreatitis, chronic pancreatitis, intensive care, and various other topics. And the technical support for all these online sessions is provided by the team of Dr. Avinash Tank, my former fellow from SGBGI, who's currently at Ahmedabad. And they have uploaded all the previous sessions videos on the YouTube channel of Gastro University. So all students are welcome to watch these videos on that channel. In between the sessions, I'll keep projecting information about the new participants, new students who would like to join these sessions. And it is very heartening that although the live attendance at some of these sessions is not very high, but as we have been seeing that in the following days and weeks, the views of all the uploaded videos are in very encouraging numbers. So the efforts put in by all the faculty, both moderators and speakers, I think are being utilized by students as well as practicing surgeons, the purpose for which these sessions were started. So with that brief introduction about our online educational activity, I would like to introduce the moderators for today. Dr. V. Sitaram is one of the senior most HPB surgeons of the country. He had a long stint at the Christian Medical College in Vellore, and he's now retired, but still actively involved in academics. And I'm very grateful to him that he accepted my request to join our sessions on a regular basis as much as he can. And we look forward to his participation and contribution. And along with him, Dr. Avinash Supe, who was formerly the chief of GI surgery at KEM Hospital and is currently at the Zen Hospital. Again, a great educator of the country. So today's session will be moderated by Dr. Sitaram and Dr. Supe. There's a slight change in the sequence. Dr. Vishal Gupta is still busy in the hospital, so he's requested for the last slot. So Piyush will shift to the 7:30 slot. So with that, I hand over to Dr. Sitaram and Dr. Supe to please conduct the proceedings.
So, sir, what is the pattern? First, somebody will present and then we have a discussion, or is the kind of pattern?
Yeah, I think if you, any one of you want to make some introductory kind of remarks about the theme and general remarks, and then each presenter will have 15 minutes. You have 5 minutes for the moderators, and 10 minutes will be the question answer session. Questions will come on the chat, which Himanshi will send to me, and then I'll read them out.
Sure.
Yes, please.
Sitaram, you want to start first?
No, I think you go ahead.
Sure. I think thank you, Dr. Kapoor. I think everybody in his lifetime as a surgeon always undergoes anastomotic leak. I think if you're not got anastomotic leak, that means you're not done enough amount of anastomosis. That's I would say. So I think this is a very important topic, and I really appreciate Dr. Kapoor's efforts of really spreading this. And I would request the first person to really start his presentation. And I'm sure I request everyone who has any questions can send them to Dr. Kapoor, and then we will definitely solve all these questions.
We'll introduce the first speaker. First speaker is Dr. Anshuman Pandey. He again is my former fellow from SGPGI, and now he is the chief of surgical gastroenterology at the RML Institute of Medical Sciences in Lucknow, another tertiary care level institution founded by the government of UP. And Anshuman is going to talk to us about the techniques of anastomosis. Anshuman, please.
Good evening, everyone.
I always feel that anastomotic leak, different organs have different kind of and the risk which is always involved. And there are, I'm sure, many elements of anastomotic leak. It's not only your technique, but how you really select a patient, what is the disease pathology, what are the way you really use your instruments and your sutures, and overall post-operative management really has a lot of involvement into anastomotic leak. So anastomotic leak should not be really said it's only technical fault. No, it's not a surgeon's fault alone. It has many factors. So I think one should understand this. So if you understand that, especially your surgical decisions of where to do anastomosis and the vascularity of that anastomosis, if you understand that, I think that many times is the reason for getting anastomotic leak. So I think when we understand this topic from beginning, from anatomy to almost the way you diagnose, what are the early features of diagnosis, I think we must really understand that there are some factors which are under control of surgeon and some are not under control of surgeon, directly or indirectly. If you understand this, actually, Anshuman, your hospital looks lovely.
So, good evening, everyone. It's a very interesting topic. Why? Because it's a very basic one. And as my moderator has said, that everybody who hasn't got a leak hasn't been performing surgery. So, it's a Greek word, and it shows that anything without a stoma or a mouth would be as termed as anastomosis. So, it's a very simple thing that a key to a successful anastomosis is an accurate union of two viable bowel ends, and of course, without any tension. So, most important factors which would be important in creation of bowel anastomosis would be a meticulous technique, a proper blood supply, and it should be tension free. Now, this technique depends upon the site of anastomosis, the caliber of the bowel being anastomosed, the underlying disease processes, contamination prior to your surgery, that is an emergency setting or an elective setting, a perforation, any kind of vascular compromise, trauma, and associated bowel edema, the available expertise, time, and of course, the equipment and the things which are available at that point in time whereby a person is performing the anastomosis. So, one important factor to perform a particular anastomosis remains, however, the experience of a surgeon, which is of paramount importance. The intestine tissue or intestinal tissue should be opposed with the serosa to serosa component, and the mucosa should not be pouting out or it should not be visible from outside, as it should be inverted rather inside. The familiarity with the tissue, that is normal, abnormal, ability to predict how it will interact with the anastomotic technique allows the surgeon to select the technique, and with optimal tissue compression. Any kind of overcompression would lead to ischemia, necrosis, distillation, or undercompression may lead to bowel not being anastomosed properly and giving rise to leak. An important aspect is the anastomotic size. What should be the anastomotic size? It should be adequate enough to and patent enough to admit regular flow of enteric contents. And it should be without generating any sufficient wall pressure to cause the disruption of the continuity of the bowel. Any kind of back pressure due to obstruction may lead to problems later. So it should be tension free, both in terms of the anastomosis and also egress and ingress. The anastomotic aperture side should be at least matching the cross-sectional area of the surrounding intestine. So it's important that not only the stoma size, especially in a side-to-side anastomosis, the aperture of the bowel, that is the lumen whereby the egress is taking place or the ingress is taking place, should also have an adequate size. It should not be obstructing at that point in time. In stapled anastomosis, which is now a big thing, especially in robotic and laparoscopic surgery. The limiting factor on flow rate across the anastomosis is not typically the anastomotic diameter itself, it is the surrounding anastomotic aperture size. The cross-sectional area or the cross-sectional diameter is the important fact because we may actually have a very big anastomotic size, but the egress is small. Tension-free anastomosis, that is, the anastomotic end should overlap without having excess tension or undue pulling. The methods for achieving tension-free anastomosis, maybe we can take an example of ileal pouchinal anastomosis, is taking or rather mobilizing the root of the mesentery. The mesenteric scoring, like a transverse cut, that is a pie crust fashion cut, whereby you may increase the mesenteric dimensions and reach the bowel to deep into the pelvis. And sometimes a ligate, a vascular pedicle, that is ileocholic pedicle in this case, whereby you can reach the bowel to a certain extent. So all these maneuvers are done predominantly to have a tension-free anastomosis. If it is tense, it may give rise to problems and leak. There are multiple procedures or maneuvers which have been described, and all these procedures are prescribed for specific surgeries, like one of them is Deloitte's, and this is what it looks like. One of the most important thing would be the adequate perfusion, which leads to proper healing of the tissue, and it actually is the key to prevent any kind of anastomotic leak. So on table, one may assess adequate perfusion by the color of the bowel, which was described very well by Goliga. It should be ideally pink and healthy, and sometimes, if you just press upon it, it actually blanches and comes back to its normal self. Observing the pulsatile flow at the cut section, once you cut with the scissors or sometimes even with the cautery, it may have proper blood supply, which was described by Norman and Louise. Sometimes you may even go to the mesentery and see whether it is pulsatile, whether there's adequate blood flow or not. So all these things actually decide that whether the transaction line is having an adequate blood supply. Sometimes nowadays we have got more reliable and objective methods of assessment. It may be a handheld Doppler or a digital Doppler ultrasound or even a bigger Doppler ultrasound, a spectroscopy, a light spectroscopy, fluorescent techniques which utilize the fluorescence perfusion angiography, and laser spectral contrast imaging, which may be dye-free. So this is how it looks like. It may be done laparoscopically also, even in open techniques. The fluorescence perfusion, we may actually see whether what is the transaction line. It is very beautifully depicted over here with maybe infrared or even ultraviolet rays. The laser spectral contrast imaging, here we can see that the laser is being depicted in the small bowel and the terminal part of the bowel, which is actually looking normal in the right-hand side of the picture on my screen. It does not have a proper blood supply. So it may be a potential area to leak if we anastomosis in this area. The other factors which are affecting anastomotic leak are not necessarily related to the technique itself. It may be because of the patient conditions also, the emergency settings. The positive factors are accurate seromuscular apposition, no distal obstruction, and of course, not giving rise to any kind of mesenteric window, closing all the mesenteric window so that an adequate blood supply and there's no tension of the bowel movement later, whereby the bowel may migrate to an area which may lead to any kind of vascular compromise. The negative factors may be a significant amount of fecal contamination, a hematoma formation, which is done at the time of surgery. You may have a large hematoma, and sometimes you may actually have to wait and see whether you need to re-resect once a hematoma is large enough, which may actually jeopardize your anastomosis. The patient factors are important. A proper patient with a young, good nutritional status, hemodynamic stability is there, the healthy bowel ends are there, the good vascular supply, a non-smoker patient. So all these things would be the positive factors. Any patient who is immunocompromised on high dose of steroids, an elderly male or female, Anemia is an important factor. Sometimes underlying medical conditions like diabetes, which is uncontrolled uremia, may give rise to your bowel leaking. Antecedent history of continuous smoking, alcohol abuse. Nowadays, although this is mentioned there, but preoperative radiotherapy, but nowadays we operate in neoadjuvant setting also. So it may be questionable, but still, newer techniques of radiotherapy whereby they deliver concentrated radiation at the area may actually be better rather than giving a general radiotherapy. And one of the factors may be male sex in colorectal anastomosis, may be due to anatomy, may be due to vascular supply. So this is the basic phase of healing, whereby within hours we have inflammation, whereby the platelets, keratinocytes, cytokines come. In days they have proliferation, whereby the pro-inflammatory macrophages and neutrophils come. And then subsequently the remodeling part, whereby the collagen fibers form. And this usually happens in weeks. So one initial part of the time, you have to give proper, decent anastomosis to the patient so that the remodeling occurs properly. So anastomosis can be described as sutured anastomosis or stapled anastomosis. It may be simply interrupted or continuous with single layer sutured anastomosis or a double layer sutured anastomosis, an end-to-end anastomosis, side-to-side anastomosis. End-to-side anastomosis means the proximal and the distal end relationship in terms of end-to-end, the side-to-side, and end-to-side. It may be extramucosal, that is onto the serosa, or full thickness sutures. So all these things are basic things. You may have variations of it, but these are the types of sutured anastomosis. The stapled anastomosis, again, it may be side to side or end to side, and they are dependent on various stapling devices. Nowadays, it is nearly universal to have a three-row staple, which is known as tri-staple technology, which is used in our scenario, which we'll discuss. So sutured anastomosis, technically, it is two ends using sutures and needles. Healing of anastomosis and recovery from the surgical damage is both impacted by the suture material and the structure. So an ideal suture, maybe people say that an ideal suture is not made as yet, but still it should cause minimal inflammation and minimal tissue reaction and provide adequate or maximum strength during the lag phase of wound healing. Once the wound is healed, then the collagen is formed, properly remodeling is done, then the suture may actually be absorbed. So popular choices, polygalactin, that is Vicryl, polydioxazone, that is PDS, and silk. Apart from that, there are various other sutures which are usually used. So synthetic absorbable monofilament suture materials are usually preferred. They are absorbed primarily by hydrolysis, hence they have a predictable outcome. Monofilament sutures are usually less traumatic as compared to the braided ones, but sometimes they have more memory that is difficult to handle, especially in laparoscopic scenario. But still, monofilament sutures are preferred. Nowadays, we have braided sutures also, but again, that is a separate scenario. Monofilament sutures are usually preferred. Small suture material 3-0 would are less likely rather to trigger inflammation. So 3-0 suture with an adequate size is a good enough scenario, and most of the centers they use 3-0 sutures. Just a word about the types of sutures. We know about the Lambert sutures. There may be multiple variations of it, but still it holds the test of time. That outer layer of two-layered bowel anastomosis, 3 to 4 millimeter lateral to the incision. They are usually only seromuscular, and they may be interrupted or continuous in manner, and they repair the seromuscular tears too. Another form of suture is the Halsted or the horizontal mattress. Now, this is an important suture. Why? Because some people use it in the anterior component of the invagination technique of the pancreatico jejunostomy also. It distributes tension in a plane perpendicular to that of a Lambert suture, and it is usually a horizontal mattress. We just show you the picture. The apposition of tissues has less crushing effect. They are more opposed rather than crushed together. And it is useful predominantly in damaged, inflamed, or soft tissue, which is handled with care. Another component is Zerny's Lambert suture, that is double layered. Some people consider it as a gold standard for bowel anastomosis. The inner full thickness, continuous absorbable sutures, and outer layer of interrupted, often permanent seromuscular or Lambert sutures. So this is the most commonly done scenario whereby the inner sutures are absorbable sutures and they may be continuous or interrupted depending on the preference. But usually interrupted is preferred in terms of this thing because the continuous sutures may actually compromise on the luminal vascular supply. Another suture is Gamby suture, which was essentially used in pyloroplasty, which is an interrupted single layer suture, and it inverts mucosa, creates full thickness inverting suture line, and used typically absorbable sutures are used. Another form of suture is cornel suture. They are full thickness, usually continuous. The mucosa is inverted into the lumen of the bowel anastomosis, that is the knot inside the lumen, and absorbable sutures are generally used in this scenario also. Cushing suture, same as cornel, except the suture does not enter the lumen, but it rather exits through the submucosa rather than the luminal knot. So these are a few pictorial things. Interrupted Lambert, continuous Lambert, Cushing's. One of the sutures is a purse string, cornel suture, and on the right-hand side extreme is the Halstead suture used in difficult tissue scenario whereby the sutures are not holding very well. So single or double layer anastomosis, of course, everybody does it with their own experience. Neither technique is inferior in terms of preventing any kind of scenario post-operatively. But single layer anastomosis is simpler, less expensive, as they say, quicker to perform. Reductions in ischemia, that is the most important thing, tissue necrosis and narrowing of the lumen. So, anastomosis in trauma, especially, gravitates towards double layer anastomosis because sometimes the inner layer only or a single layer anastomosis may create problems. Interrupted versus continuous sutures. Continuous sutures are usually watertight. They improved hemostasis is there, but sometimes integrity is only on one stitch. Subsequently, they may lead to ischemia and hence any kind of bowel disease. So studies, they show the references are there that continuous anastomosis can be performed safely and quickly. And although there's no significant difference between continuous and interrupted suture patterns, but usually teaching says that in a difficult scenario, we should use interrupted sutures because any kind of a purse stringing effect or any kind of difficult scenario in terms of ischemia should not be compromising the bowel at that point in time because that is already compromised. A word about inverting and everting. Nowadays, it is confirmed that everting sutures are usually not indicated and inversion techniques are better because the mucosas are buried inside and it gives rise to superior bursting pressure, more prompt bowel architecture. Therefore, the inversion techniques are better. Here are a few pictures whereby we see that although it is a bit of zoomed out picture, but still we can see that a side to side anastomosis is being done in typically four layers, the inner two and outer two. The inner layer is absorbable, which is vicryl, and outer layer is simple. Again, a sutured end to side colocolic anastomosis. The end and the side here, again, a single layer suture is done with a silk suture. A word about stapled anastomosis. Nowadays, a lot of stapled anastomosis is being done. They again, the surgical principle remains the same. They ensure viability and reasonable condition of the tissues to be manipulated. They exclude a distal obstruction is must. Carefully evaluate the areas that have experienced radiation, peritonitis, local changes, and avoid tension on the staple lines, as was the case in terms of suture 2. We have to have precise dissecting of the tissues and in which are basically incorporated inside the anastomosis. So the most important thing is adequate compression to cause hemostasis and prevent leakage. Most of these stapled anastomosis are done laparoscopically or robotically. So you have a loss of tactile sensation, but there has to be an adequate hemostasis and compression, thereby leading to an adequate anastomosis. We have to ensure that the staple is properly loaded and configured in proper orientation. The safety mechanism are usually done left at the last moment, that is, once the compression is complete and we are ready to deploy the stapling or staple line. Usually, a bit of time has to be given so that the bowel edema and compression moves away from the staple line and there is an adequate anastomosis. If the bowel is very edematous, sometimes you may actually tear the bowel and it may lead to problems in terms of anastomosis. The force use has to be gentle and it has to be in a proper fashion. And nowadays we have got mechanized staplers also, whereby they distribute the force in an adequate fashion. And we should always check for any kind of staple line bleed. Sometimes we can lift it up even in laparoscopy and see, and be prepared to oversee or repair any kind of problem which is occurring at that point in time. We have always to check for anastomosis and its integrity. The types of staplers, again, linear non-cutting, that is a TA staplers. We have all used it, in, especially in low anterior resection of the bowel. That is the only staple. Nowadays, it has come in tri-staple also, a few companies have come through, but usually it is a double staggered layer of staples. The third layer of staple is usually found in the vascular subtype. The closure of the hollow viscous end incision, that is enterotomies and ligation of large vessels, can also be done with this thing. The most commonly used are linear cutting staplers, that is GIA staplers. Both closes and transects the hollow viscera. First, delivering double, triple staggered rows of staple lines. And of course, after deploying the staple lines, they have a knife whereby you actually slide the knife and they cut it in between the 3 rows on either side. So they usually transect the tubular structures and may even create side-to-side anastomosis. Sometimes it may also be used to resect solid organs, and it is usually done in bariatric or metabolic surgeries. So these are the vascular staple lines, and in between there are circular staplers which have usually a detachable anvil, that is the head. They place a circular double row. Nowadays, we also have a triple row, but double staggered row is the most commonly used. The diameter, that is the head diameter, and the staple line diameter, which is maybe in younger patients or kids, we may use 21, but usually the size is 33 millimeters in transverse diameter. Now, variably tight to close the staple height of 1 to 2.5 millimeter. It is used for inverted end-to-end or end-to-side anastomosis and may even be used in side-to-side, but usually it is not preferred. So this is the TA stapler. I have shown it from the Covidian or Medtronic. These are the circular staplers and laparoscopic staplers. The most important thing is the closed staple line and the open staple line. There are multiple colors available. The most important aspect is that the white is having the closest staple height line. So in thin or mesenteric or sometimes vascular area, you may use white. The blue, the open length is 3.5, but the close is 1.5. It is for the regular use. Gold for regular and thick, 1.8. Green for 2. So thicker tissues, you should use all these colors. Black, sometimes we use it for pylorus and adjacent to the pylorus, and also in the GE junction, the black staple, which has got 2.3, and it is the thickest as of now in the discount part. We have thicker staplers also, but this is the commonly used. These are the few pictorial representations. This is the tri-staple low from Ethicon, the upper one. It is cutting through the bowel, and we are doing staple side-to-side anastomosis. The end here is sutured, which is shown in the right extreme corner. This is the circular stapler, which is firing through the anvil, and it is stapled end to side anastomosis. These are the staplers used for OAGB or one anastomosis gastric bypass, or also termed as MGB. Here we see that over a Bouginage, we have opened the stapler, the second picture, after firing the stapler. It is a mechanized stapler, and then subsequently we are doing a gastrojejunostomy and closing the lumen after doing the anastomosis over with sutures. Sutures usually we use absorbable ones in this scenario, and we use two layers of sutures over here. This is again a pictorial representation of an endo-GIA stapler, three-line stapler used laparoscopically, and whereby we may use it in LAR or APR. Finally, a word about suturing versus stapling. Both suturing and stapling techniques can be performed safely throughout the GI tract, and no significant differences are seen between clinical leak, morbidity, and even mortality. The studies have investigated the benefits of particular technique in specific situations. The staple versus hand swing, there's a Cochrane review whereby it suggests that stapled side to side anastomosis is recommended following right hemicolectomy, particularly if performed for colonic adenocarcinoma. Side to side staple anastomosis, especially in Crohn's disease, it is not recommended to do a end to end anastomosis here. The majority of evidence considers or rather currently favors stapled side to side alveolar anastomosis in Crohn's disease. But suturing may be an equivalent scenario. Especially in esophagus, sometimes the use of the stapler over the suturing line has also been suggested, especially in esophagogastric anastomosis. But here, one of the randomized study in hand-sewn anastomosis and stapled anastomosis, one suggested that more anastomotic leak in hand-sewn anastomosis and more anastomotic stricture also in hand-sewn anastomosis. So a strong indication was made for a stapled anastomosis. So stapled versus hand-sewn anastomosis in colorectal surgery, the evidences did not find or indicate any superiority over hand-sewn techniques in colorectal anastomosis. And it was regardless of the site of the anastomosis also, whether low down, upper, this thing, or even this thing. Sometimes people say that only the lower component is for stapled and rest of the things should be hand-sewn, but the evidence suggests otherwise. So thank you for all the patient hearing. I hope I have stuck to my time. It was a brief overview of the techniques of anastomosis. Thank you.